Madam, we are live now.
Okay.
So good evening, doctors and all the participants. I Shuman on behalf of Shield Healthcare, welcoming you all to today's session on management of urinary tract infection. And our guest speaker is Dr. Priyanka Velchamy, madam. Before moving into the session, let's have a look on our Shield Connect platform. This is basically a knowledge sharing platform of Shield Healthcare. And here you can find the blog section. You can find many topics in terms of many area, and these blogs are endorsed by many senior doctors and gynecologists as well. And these are the webinar section. You can find upcoming webinars and past webinars, and in the awareness tab also you will find all the related topics on this PCOS, menopause, GDM, and many other things. And the most important thing is our key opinion leaders. So presently more than 700 doctors are currently supporting us, this knowledge sharing initiative of Shield Healthcare. So I request all the participants, please have a look on this website. It's very important in terms of our subject area. So now it's time to start the session with Madam. And before that, it's my honor to introduce Madam. Madam DGO, Fellow Accessory Surgery, Fellow ART. Madam is a consultant OBGYN at Deepan Hospital, Trichy. And Madam presented many posters and many lectures attended in AICOG, WOPOXI, ISAR, and various national and international conferences. So Madam conducted many awareness program on cervical and breast cancer and menstrual hygiene also, and actively she is conducting high risk deliveries and doing gynae and laparoscopic surgeries. So with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much once again, Madam, for your valuable time on our platform Shield Connect, and over to you for further proceedings. Thank you very much.
Thank you so much for the kind introduction. I thank Shield Healthcare for giving me this opportunity to share some information regarding certain topics. So moving on with the topic, today we'll be talking about the management of UTI in female patients. So what exactly is UTI? UTI is a urinary tract infection. So it can be infection of either starting from lower from the urethra, it can be to the bladder, to the ureters, or to the kidney. As and when the infection becomes severe, it ascends up and up. So there are lots of infections that involve the bladder and the urethra. So normally, most of the time, it is asymptomatic. Like we don't even feel the symptoms. Our own natural defense mechanism, it clears out the microorganisms in about 10 to 30%. In about 1 to 4%, it progresses to acute cystitis, and only in about 0.5 to 2%, it progresses to acute pyelonephritis. So the incidence of bacteria is more common in women and even more common in pregnant women. And the chances of progression to pyelonephritis is also significantly higher, especially in pregnant women, because of the physiological changes that happen during the pregnancy. So we have to be very careful in pregnant women, even like that's why we do the urine routine regularly every 2 to 3 months in pregnant women, whether they have symptoms or not. And once they have this urinary tract infection, it's very important to take care that they are not having recurrence and do routine testing to find out the recurrence, even to find out the asymptomatic bacteria, which has to be treated for the pregnant women especially. So UTI is the second most common infection following the respiratory infections, and 40% of the women will suffer with at least one UTI at some point of their life. And 1 in 5 women between 20 to 65 years of age suffer one attack per year. So it's that common. And approximately 30% of the pregnant women suffer from UTI. So what is the cause of UTI? So it may be because because of women due to the anatomical disadvantage of having a shorter urethra, the physiological changes that happen in a lady. Then there may be because of introduction of harmful bacteria from the GI tract, unhygienic practices, or due to frequent sexual intercourse or multiple partners. There may also be, it may also be because of this birth control methods, which may reduce a little bit of the motility of the cilia and introduce the harmful bacteria. And because of catheters, pregnancy, which causes the alteration in the women's system, hormonal system, and immunosuppressed people, people with diabetes, which cause alteration in the pH and defect in the immune system, and in postmenopausal women due to the changes during the postmenopausal period due to reduction in estrogen and progesterone. So UTI, basically it can be either uncomplicated or complicated. So uncomplicated UTI, both, it's like, as I've already discussed, female age, older age is a more common cause for uncomplicated UTI. And the most common organism in this is E. coli. In both of the cases, E. coli is the most common organism, and the second most is Klebsiella pneumoniae, and then Staph spirophyleticus, and then the others. And when it goes into complicated UTI, it is mainly in people who are having indwelling catheters, or they are having immunosuppression, or because of any urinary tract abnormalities, or due to frequent antibiotic exposure, which also reduces the immunity. So what is basically our urinary defense mechanism? So one is in the urine itself, and other is the mucosal immunity. In urine, basically we have acidic pH, so which is intolerable by the pathogens. Then this high urine osmolality, then urinary inhibitors of bacterial adherence, competitive inhibitors of attachment to uroepithelial cells, and mechanical flushing of urine flow. Mucosal immunity, basically it's a urothelial secretion of cytokines and chemokines. This mucopolysaccharide lining of the epithelium, which increases the difficulty of bacterial penetration, the antibodies in the mucosa IgA, and in men, the prostratic secretions which contain bactericidal zinc, and the urethra is longer, so that itself is protective. So what are the three major types, as we have already discussed before? Asymptomatic bacteria, acute cystitis, and pyelonephritis. So asymptomatic bacteria, it is defined as persistent colonization of the urinary tract by significant numbers of bacteria in the women, but without urinary symptoms. Acute cystitis is because of presence of symptoms such as dysuria, urgency, frequency, nocturia, hematuria, and suprapubic discomfort in afebrile women, and no evidence of systemic illness. Pyelonephritis, it's significant bacteria along with systemic illness, such as severe fever with rigor, flank pain, vomiting, nausea, etc. So what basically happens during UTI? So usually it starts from the urethra. There's also chances of systemic spread, a systemic infection which can spread to kidney, but most of the time the start is from the urethra. So there is first colonization of the bacteria, the pathogen. It colonizes in the periurethral region, and then in ascends towards the bladder. Then in the bladder, what happens is the uroepithelial penetration. So fimbria allow the bladder epithelial cell attachment and penetration, and following penetration, bacteria continue to replicate and may form biofilms. So after it crosses the barrier that is provided naturally by our body, once it starts colonizing in the bladder, then the symptoms become obvious. That is because of increased multiplication of the bacteria and the epithelial cell attachment to the bladder. Then slowly, once there is enough number of bacteria which has colonized the bladder, and then starts ascent to the ureters. So the fimbria and the ureters that may also aid in the ascent of this process. Bacterial toxins play an important role by inhibiting peristalsis and reducing the flow of urine. And then it involves the kidney, causing pyelonephritis. So pyelonephritis, the infection of the renal parenchyma, which causes the inflammatory response called as pyelonephritis. So while the infection of the parenchyma is usually the result of bacterial ascent, but it may also be because of hematological spread. And in the end, when this inflammation becomes very high and it becomes very severe, it causes acute renal injury. And the inflammatory cascade continues, and there's tubular destruction and damage, and there's interstitial edema, interstitial nephritis, and that causes acute kidney injury. So what are the risk factors? We have already seen superficially, so in detail. So it may be iatrogenic, behavioral, anatomic, physiologic, or genetic. So iatrogenic is because of indwelling catheter, antibiotic use, spermicides. So as I already told, like indwelling catheters, they provide a nice environment for the bacteria to multiply and easily ascend into the bladder. And also the antibiotic use, it disrupts the normal bacterial flora that is there in the urinary tract, in the urethra, and in the vagina and perineal region. Again, the spermicides, they cause irritation in the perineal region, so it helps in the attachment of the pathogenic organism. Behavioral risk factor. So that may be one because of voiding dysfunction or because of frequent or recent sexual intercourse. So voiding dysfunction, what it causes, the urine is not voided completely. There is post-residual volume. So when there is stasis of the urine over a long period of time, it provides a good culture medium for the growth of the bacteria. Then frequent sexual intercourse, it also it can introduce bacteria into the urinary tract if unhygienic practices are maintained. Then what are the anatomical and physiological changes? So it may be because of vesico-urethral reflex, which causes urinary retention and bacterial growth. And females, as we know, they have short urethra, 4 centimeter versus 25 centimeters in male. That itself is a high risk. And pregnancy, further, it causes progesterone-mediated smooth muscle relaxation of the bladder and ureters. And then there's compression of the ureters by the uterus, urinary retention is there. So all this increases the bacterial growth in pregnancy. Then there are certain genetic factors. So in certain families, there's increased occurrence of UTI. These people have uroepithelial cells which are more susceptible because they secrete less IgE antibodies, which is the main humoral defense mechanism at the mucosa. And there may be the properties of the vaginal mucosa, which may allow the E. coli to bind more readily. So that also increases the chances of infection. So symptoms, as we've already discussed, were praying, burning, micturition, maybe fever, chills, or malaise, hematuria, pain in the lower abdomen, that's blood-tinged urine, cystitis, which may cause frequency, urgency, foul-smelling urine. And the common causative organisms, as we already discussed, in E. coli, which is the cause of 80% of the causes of urinary tract infection. Then Enterococcus, Klebsiella, Enterobacter, Serratia, Proteus, Pseudomonas, Staphylococcus, and the list goes on. So what is the natural defense mechanism for UTI in our body? So as we already discussed, urine is more acidic, and it becomes even more acidic during UTI, which kills most of the bacteria. There is D-mannose in the urinary tract, which does not allow the bacteria to stick to the uroepithelial wall. And the bacteria that's moving upwards is normally, it is flushed out by the regular urination by the body, frequent urination by the body. So that is the cause of this symptoms associated with UTI. So sometimes it gets cleared out and then sometimes it needs our help. So most common form of recurrent UTI is recurrent or persistent asymptomatic bacteria. And as it progresses, it may go to cystitis or pyelonephritis. So asymptomatic bacteria, according to the Infectious Disease Society of America, it is significant bacteria is when in the bacterial monoculture, there is a quantity of greater than 10 to the power 5 colony forming units per ml in 2 consecutive midstream clean catch urine specimens, or more than 10 to the power 2 colony forming units per ml in a single bladder catheterization sample. And screening for bacteria by American College of Gynecologists and AAP, it has been told that every time we have to screen a woman with who's pregnant, especially in the first visit or at 12 weeks for urinary tract infection, whether she's symptomatic or not. Every trimester minimum we have to do one urine routine testing to screen for bacteria. Acute cystitis, it affects approximately 1% of all the pregnant women. And it, as discussed, it results because of ascending infection because of a long-standing bacteria, asymptomatic bacteria. Again, the symptoms already discussed: dysuria, frequency, urgency, pain, hematuria, all these things. And pyelonephritis. So this is one very serious common complication in pregnancy. So that's why it's very important that we have to find out bacteria in the very early stages, because it can cause septic shock during pregnancy, and it causes severe febrile illness and severe pain and severe affection of the kidney of the pregnant woman. And the symptoms: there's abrupt onset of fever, chills, there's aching pain in one or more of the lumbar regions, there's anorexia, vomiting, severe tenderness, especially at the costovertebral angles. And the organisms, as discussed, the commonest organism anywhere, everywhere, it's E. coli, followed by Klebsiella pneumoniae and Enterobacter, Proteus, and gram-positive organisms. So how to diagnose pyelonephritis? So clinically, on seeing the patient itself, we can come to a conclusion about the severity of the urinary tract infection. Gold standard is renal biopsy, but definitely we don't do that in clinical practice. So we can do a panel of complete blood count and the inflammatory markers, CRP, renal function test, urine culture, blood culture, and sensitivity. All these things can be used definitely to confirm the diagnosis and to help with our treatment. So what are the medical complications that occur because of acute pyelonephritis? So basically there is endotoxin-induced alveolar injury. These manifest in about 10% of the women and may result in frank pulmonary edema, and it may be severe enough to cause acute respiratory distress syndrome. This endotoxin also causes hemolysis and can cause anemia, and bacteremia. It is demonstrated in 50 to 20% of these cases, and there is transient renal dysfunction in 2% of the cases. So how does this pyelonephritis affect the pregnancy, the obstetric complications? There are preterm labor, preeclampsia, infection, chorionitis, postpartum endometritis, and the fetal complications, of course, because of preterm labor and poor development of the fetus, is low birth weight, prematurity, a developmental delay, mental retardation, perinatal mortality. So that's why the severe disease, it affects very badly the mother and the fetus. And what else can be the differential diagnosis in case of the symptoms that are similar to acute pyelonephritis, that may chorionitis, appendicitis, placental abruption, or infracted leiomyoma. So we have to keep in mind all these things when we have the symptoms of lower abdominal pain and fever, and then we have to come to a proper conclusion. Now, what will be the treatment options? So at a basic level, when it's just very early, like it's asymptomatic bacteria or just very early development of symptoms, we can use alkalizers to relieve the burning micturition, antispasmodics to relieve the pain and spasm. You can use cranberry extract to flush out the bacteria, and then in the end, antibiotic to eradicate the bacteria when nothing else works. So how do you go for the antibiotic treatment? So antibiotic, there's like we can't say you have to use this or that. According to the severity of the disease and according to the patient requirement, we have to titrate the dose and the duration of the antibiotic. In early stage, when it's asymptomatic bacteria, just a single dose and a short course of 3 days is enough. Like single dose like amoxicillin 3 gram, cephalosporin 2 gram, trimethoprim sulfmetazole 320 by 1600 gram, or the commonly used 3-course regimen, amoxicillin 500 milligram 3 times a day, ampicillin 250 4 times a day, and the ciproflox, norflox that we commonly used twice daily, nitrofurantoin, which we can very well use easily in the pregnant patient, 50 to 100 milligrams 4 times daily or 100 milligram twice daily. So these are other doses of nitrofurantoin, which can be given 5 to 7 days or 10 days, or in case of prophylaxis, it can extend up to 21 days. And definitely after any course of treatment, any episode of bacteriuria, we should have a periodic screening. Anyways, we are going to screen periodically, but definitely after if there's a bacteria, we should not forget to do the screening so as to prevent the recurrent infection. And follow-up cultures should be obtained after the completion of the treatment, either it is 1 or 2 weeks, and then again after a month. And when there is persistent recurrent bacteria, nitrofurantoin 50 to 100 milligram at bedtime until the end of the pregnancy. A postpartum urological evaluation has to be done in patients with recurrent infection because they are more likely to have structural abnormalities of the renal system. Acute cystitis management will be again increasing the oral fluid intake. That's definitely the first time. But when we are coming to cystitis, we are well past the oral fluid intake. We have to go to the antibiotics apart from the alkalizing agent, etc. Pyelonephritis, definitely we have to hospitalize the patient. We have to give IV antibiotics. We have to obtain urine after taking the investigations, especially for the urine and the blood culture. And we have to do a hemogram, consider the electrolyte and RFT, creatinine, uric acid, and the tests all, and do the CRP. We have to monitor the patient very closely, carefully, the vital signs. We have to catheterize the patient to monitor the urinary output. And when the urinary output is less than 50 ml per hour, we have to give the intravenous crystalloid solution also. In acute pyelonephritis, so we have, after taking all the investigations, we have to immediately start on with the intravenous antimicrobial therapy. And in case of there is any symptoms of dyspnea or tachypnea, we have to do a chest radiograph, a CT, then repeat the hematological and chemistry studies again in 48 hours. And as soon as the culture report and all comes, confirm whether the antibiotics that we are giving is in sync, is sensitive, the bacteria sensitive for that antimicrobial or not, or according to that, we have to change the antimicrobial. And before the discharge of the patient, we have to change it to oral antimicrobials. And pyelonephritis, definitely, we have to continue the antimicrobial therapy for more than 10 days. So we have to change from IV to oral, then there is a minimum of 48 hours of afebrile period. Okay, and after the completion of the treatment, oral antibiotics, we have to repeat the urine culture immediately at the end of the oral antimicrobial treatment, and again after 1 month to rule out any recurrence. So such very close follow-up is required, especially in patients with acute pyelonephritis. So we can also give non-steroidal anti-inflammatory drugs for symptomatic relief, but in pregnant patients, we have to be very careful regarding giving NSAIDs because causes premature closure of ductus arteriosus, oligohydramnios, gastric ulceration, again reduction in renal perfusion. So we have to try not to give too much of non-steroidal anti-inflammatory drugs to the pregnant patients until unless it's absolutely necessary, and it has to be to the minimal. And also thromboprophylaxis has to be considered if the woman has reduced mobility or is in a period of bed rest. We can use compression stockings and low molecular weight heparin as and when needed. So as already discussed, antimicrobial treatment should continue for more than 10 days and may go on up to a 14 to 21 day period according to the condition of the patient and like the comorbidities of the patient. Sometimes we might even have to continue the antimicrobial treatment throughout the pregnancy. And the most common reason for initial treatment failure is this uropathogen resistance to antimicrobial treatment. So we have to take the culture and diligently follow the results and see whether the antimicrobials that we are giving are sensitive, the organisms are sensitive to that. And we have to rule out any underlying renal tract anomaly, underlying pathology. Calculi, renal calculi, all these things should also be ruled out. Now, what will be the antimicrobial of choice in acute pyelonephritis? So for the ceftriaxone, 1 gram every 24 hours. In pregnant women, after second or third trimester, we have to give up to 2 gram every 24 hours because of the increase in the body mass index. Cefepime, 1 gram every 24 hours. Amoxicillin with clavulanic acid, 1.2 gram every 12 hours. Azithromycin, 1 gram every 8 to 12 hours. And in severe acute pyelonephritis or in case of immunosuppression or urinary stasis, they have to go one step further. That is tetracycline with clavulanic acid, 3.1 gram every 6 hours. Piperacillin with tazobactam, 3.375 gram every 6 hours. Meropenem, 0.5 gram every 8 hours. Itrapenem, 1 gram every 24 hours. And doripenem, 1 gram every 8 hours. So this is the FDA category for antimicrobials that are indicated in pregnancy. So most of the antimicrobials come in group B or group C, and the commonly used that we use are all like amoxicillin, cephalosporins, azithromycin, erythromycin, clindamycin, nitrofurantoin. All these come under category B. And when we need to go to one step higher, we can, if really needed, we can move on to the category C drugs like the floxacin, levofloxacin, norflox, linezolid, clarithromycin. So all these are category C drugs. So we have to keep in mind these basic categories so as to give it according to the patient. Now, nutraceuticals, it's like nowadays, before or along with antibiotics, we have started to give certain more medications which help or are adjuvant to the antimicrobial activity of the drugs. So one is this ursolic acid, which is a powerful anti-inflammatory and analgesic. It inhibits pro-inflammatory cytokines TNF-alpha and prostaglandin E2. The anti-inflammatory effect is comparable to indomethacin, a powerful NSAID. It is a powerful antioxidant. and it prevents tissue damage and inflammation due to reactive oxygen species. So there's certain clinical evidence also for the use of ursolic acid. One more that we've been commonly using, potassium magnesium citrate. It provides high concentration of bicarbonate in urine. It neutralizes the acidity of the urine, and hence it very much helps in relieving the burning micturition. That's a very irritating symptom during this urinary tract infection. And mannose. Mannose is like, already we have some amount of mannose in our uroepithelial cells. It's a structure, D-mannose is a similar structure to the binding site of uroepithelial glycoprotein receptors such as uroplakin. So saturation of film H adhesions and the prevention, this prevents a bacteria from binding to the uroepithelial glycoprotein receptor if it is present in sufficient concentration in the urine. So this binds to these receptors and it prevents the bacteria from binding so that it gets flushed out, the bacteria gets flushed out. One more is proanthocidin A, which is an active ingredient of cranberry. 3 types, A, B, and B2. Pack A, Pack B, and B2. So Pack A, how does it act? Fructose inhibits the type 1, the binding of type 1 fimbriate to the uroplankin receptors. And proanthocidins prevent the binding of P fimbriate, this P fimbriate, to the glycolipid receptor. So it prevents this. There's this fimbria on the E. coli, which binds to the epithelial cells, urothelial cells. So proanthocidin, it prevents the binding of this fimbria to the uroepithelial cells. So the ideal initial treatment to relieve all these symptoms will be a combination of all these: ursolic acid, potassium magnesium citrate, cranberry extract, mannose. So all these are very much useful in the initial management and provide very good symptomatic relief in the initial stages of urinary tract infection. So summary. So females are more prone to develop UTI than male. 40% of women will suffer at least one UTI at some point in their life. And the incidence of bacteria is quite higher in pregnant women than non-pregnant women. And the chances of progression to pyelonephritis is significantly higher in them. There's high chance of pregnancy complications if there's untreated UTI for a long time. And first-line therapy, it includes the antibiotics. And the nutraceuticals can be used to provide relief from the different symptoms of the urinary tract infections, such as pain, burning sensation, and it also helps additionally to flush out the bacteria. Thank you so much.
Thank you very much, madam, for this nice presentation. Just give me 1 minute time, ma'am, to check the questions even.
Yeah.
Madam, one question is, there are a few research articles that suggest that continuous use of OCPs can lead to recurrent UTI. So your thought on that?
Yeah, definitely. Oral contraceptive pills, they reduce the motility of the cilia and the urinary tract, and it causes stasis of urine also. So there is a chance of one of the side effects of using OC pills for a long time is UTI. So we have to select the patients accordingly for the starting of OC pills.
Thank you very much, ma'am. And one question, ma'am, what are the parameters should be taken care of while treating this UTI in pregnancy in different trimesters?
So basically, we have to go we do a urine routine examination in every trimester. It's even better if you do a culture, because urine routine might not find out the asymptomatic bacteria, which is very important. We treat in the early phases without even us knowing that causes lots of trouble. So one culture in each trimester is definitely going to help. And if a patient is showing symptoms, any of the symptoms like lower abdominal pain or irritation, burning sensation, or anything like that, definitely we have to go for a culture, and we can start oral antibiotics according to the culture sensitivity in our region. We know like which antibiotics are more sensitive in our region, because there's a lot of resistance emerging these days. Usually a nitrofurantoin is quite effective. 100 milligram BD for 5 to 7 or 10 days, depending on the severity of the infection. So once you start on the antimicrobial, you send off a culture also before and wait for the results. And as soon as you get the result of the culture, you know the sensitivity of the antimicrobials. And then according to that, we can change the antimicrobial or continue whatever we are being given the patient.
Thank you very much, ma'am, for the inputs. And last question is, ma'am, what is your thought on nutraceuticals in the treatment of UTI? Your practical experience or your practical observations?
Nutraceuticals, definitely, they have an adjuvant role. Some patients, you know, we even constantly give some cranberry extract, and they feel that they have a tendency to get a burning sensation once in a while. So immediately at the start of the symptoms, when you give this nutraceuticals like mannose and cranberry extract or arsolic acid, it helps to relieve some of the symptoms. But yeah, but definitely you have to rule out whether there's an infection or not. So if there is an infection, you can't just depend on these adjuvants only. We have to start the antibiotics. These adjuvants will help to relieve the patient symptoms and as an adjuvant to the antibiotics. It's definitely useful.
Thank you very much, madam, for all the address. And I could not find any other question, ma'am. So if you allow, then we can conclude the session.
Okay, sure.
Thank you very much, madam, once again for your valuable time on our platform, Shield Connect. And it is obviously a very nice session on this very important topic, UTI. And it will be our pleasure if we can conduct any other medical session with you in future as well on our platform, Shield Connect. So thank you very much, madam, and have a good day.
Okay, thank you so much.
Thank you very much, madam.